Okay, so today we're going to talk about the management or treatment of fibroids, and this is quite an opportune time. So as you can see, I'm in a hospital and I have just completed a surgery on a big fibroid. The management of fibroid really depends on what are our aims and what are we trying to achieve. So I think we need to be clear on whether we're trying to stop bleeding, we're trying to stop pain, we want to maintain fertility, or we really don't want fertility and we just want this issue resolved. So I think if we go through the options, going from the least invasive to the most invasive, so we can think about medical options that really deal with symptom control. So at a very basic level, we can give medications that stem bleeding. So tranexamic acid is very common. It works on platelet function, and we can give that, and it's fairly effective in stopping heavy bleeding. We can give forms of progestogen like Provera that will thin the lining and therefore make the bleeding less severe. There's hormone manipulation we can do. So being on the pill is one of the most common methods of trying to manage bleeding in fibroids. The success is highly variable. In some people it will stop periods, and therefore that is good. It does what it's meant to do, but in a lot of people they still get some bleeding, or worse still, they get unpredictable heavy menstrual bleeding. What's probably more effective are the more complex ways of manipulating hormones. So that is manipulating hormones at a brain level that then influence downstream estrogen levels, and they are the ones that can actually effectively stop bleeding. So things like GnRH analogs, so injections such as Zoladex that are monthly injections, they work on a hormone linkage chain between the brain and the ovaries. And they will essentially quite effectively shrink fibroids. They often make the person amenorrheic, so that is they don't have a period, and they're generally very effective in preventing that that catastrophic hemorrhage that some people get with fibroids. The downside to something like a GnRH analog like Zoladex is that you do get menopausal symptoms, and after about 3 months you do need hormone replacement to actually combat some of the downsides of lack of hormones, such as osteoporosis and so forth. The other hormone that's out there is Ryaco. Ryaco is also a GnRH analog, but it's a short-acting analog. It's in the form of a tablet, and it actually contains both estrogen and progesterone as well. It's got some long-term data in terms of protection for the bones, but they do have a slight drop in bone mineral density, but probably not significant. They don't seem to change the volume of the fibroid too much, and that's very different from something like Zoladex, those injections that will shrink the volume of the fibroid, but they do quite significantly decrease the amount of bleeding. So symptomatically, if bleeding control is what you want, then that's something we can do. There used to be another agent called selective progesterone receptor modulators. The one that was in Australia is Earlyprist. That's now been withdrawn off the market due to liver toxicities. They were actually quite effective for bleeding and fibroids and shrinking fibroid size, but because of the toxic side effects, the regulators have withdrawn that from the market. So they're the medical side of things of managing fibroids. What about something a little bit more interventional? So there are procedures you can do under radiology guidance, such as CT and fluoroscopy, where they can actually thread a little catheter through the groin into the arteries around the fibroids, and they can actually block those arteries off. This is arterial embolization, and most commonly the artery that's embolized is the uterine artery. Uterine artery embolizations are quite good for people who don't want fertility and don't really want any more invasive surgery. Uterine artery embolizations do need specialized expertise and specialized units to do. Generally not recommended for people who are trying to fall pregnant, because it does change the blood flow around the uterus and can affect placenta function moving forward. Be very aware of using uterine artery embolization for very large fibroids as their only method of intervention. Because what happens with these fibroids is that they then sort of decay from the inside, and they can trigger an inflammatory response that's actually very painful. The other sort of semi-invasive method that uses newer technology is focused ultrasound. Focus ultrasound is directing a beam of ultrasound directly at the fibroid and producing heat and destroying the fibroid tissue. It's starting to become a treatment offered in Australia, but it's much more popular in the States. Focus ultrasounds can be done in two ways. So you can do it using MRI, so using MRI to guide the ultrasound, or you can do it via a keyhole procedure where the fibroid is physically viewed and handled, and then two ultrasound plates are placed over the fibroid and a beam of sonic energy is transmitted into the fibroid. There is just not a lot of long-term data for this type of surgery or this type of intervention, especially with long-term pregnancy data. So still very much in its early phases. There will be more research and data coming out for this. Now let's then move on to the surgery side of things. So fibroid surgery contains two main branches. The first branch is fertility-sparing surgery, and the second branch is fertility non-sparing surgery. So fertility-sparing surgery is the removal of a fibroid, so that's a myomectomy. There are some prerequisites for doing this kind of procedure, and one of them is that we need to be very sure that this is a fibroid and not something more suspicious or malignant. How you remove the fibroid depends on where the fibroid is. So fibroids that grow into the cavity itself can be removed with something called hysteroscopy. This is where a camera is inserted into the uterus and the fibroid is then gradually scraped off from an instrument on the end of that camera. So this is a hysteroscopic myomectomy. These type of fibroids that poke into the inside of the uterus, so they are associated with fertility and have been linked to implantation failure and miscarriage. And we do recommend that if you are trying to fall pregnant and you have a submucosal fibroid, you have a chat to your doctor about the viability and the benefits of removing them. If the fibroids are outside the lining, so they're either in the muscle of the uterus or on the surface of the uterus, then you do need an abdominal procedure to remove them. So an abdominal procedure is either a keyhole procedure or an open procedure where there is a larger incision made on the abdomen. Which technique you use depends on the surgeon, and it depends on the purpose of the surgery. But both of these type of procedures have in common making the incision over the uterus, shelling out the fibroid and repairing and reconstructing the uterus. These are very large operations that can have the potential to cause quite a lot of bleeding, and if they do break through the cavity, so that is the incision goes into the cavity, then the cavity needs to be carefully put together as well. Otherwise there can be scarring around the cavity and impede further fertility. Generally, fibroid removals should be done in patients who desire fertility, because in patients who do not desire fertility but want their fibroids removed, probably should consider a hysterectomy. So hysterectomy is the ultimate sort of surgery for fibroids. There is non-fertility sparing surgery, and it involves removing the uterus and the cervix and probably the fallopian tubes as well. And that, along with all of that stuff, is removed. It would be the fibroid. The hysterectomy is a bigger operation potentially, but it does mean that we don't have to cut into the fibroid to remove it, and potentially has less bleeding. If the fibroid happens to be not a fibroid, then the hysterectomy will mean that you haven't disturbed the fibroid. So you haven't upstaged, for example, a sarcoma, which looked like a fibroid, whereas if you cut into a sarcoma, thinking it's a fibroid, then you have upstaged that disease. So hysterectomies obviously is only for people who have finished their families or do not desire fertility. Hysterectomies can be done in a number of ways. Generally, these are done abdominally, so either an open procedure, a laparoscopic procedure, or a robotic procedure. So there are some people who still do vaginal hysterectomies for fibroids, but because we generally have to remove the fibroid vaginally, it does provide some access issues, but vaginal hysterectomy is also an option for fibroids. So look, that's a very quick rundown of fibroids and how we manage them. And for further detail, probably have a chat to your doctor.